Hey, everybody. Welcome back to Autism Confidential, the podcast from the National Council on Severe Autism. I am your host, Jill Escher. I am president of NCSA. Today, we have really an episode that everybody's been clamoring for. We had a lot of requests for this guest, and I'm absolutely thrilled. But before we get there, I have some housekeeping announcements. We've received really a whole lot of requests for guests on the podcast and topics on the podcast. We are getting to those slowly, just a lot on our plate. So hopefully this summer you'll see more and more of your requests actually being fulfilled. So please be patient with us. Also, we've had a couple of requests from people saying, how can you support the podcast? So I really appreciate those emails. If you go to ncsautism.org, there's a donate area there, and you can just click on donate, and there are various ways to donate to NCSA. And when you donate to NCSA, you're supporting this podcast. And if you want to earmark it, earmark it. But I really appreciate everyone who sent in that question. Thank you so much for your support. Okay, end of housekeeping. And now on to our illustrious guest. Melissa Harris is Deputy Director of the Disabled and Elderly Health Programs Group at the Centers for Medicare and Medicaid Services. She helps develop and implement policies to advance home and community-based services that are funded through Medicaid. So welcome, Melissa. Thank you so much for joining us.
Thank you, Jill, for having me. It's really my pleasure. And this is actually my very first podcast that I am participating in. So I'm excited.
Okay, well, we'll be nice and gentle, no cross-examination. But this is, and I'll tell you, let me explain to you why everyone wanted to hear from Melissa. So we have, the people who listen to this podcast have a wide variety of experience levels and backgrounds. And I just want to give just a little bit of context here. So Medicaid, as you know, is the federal program that helps fund services and medical care for adults with developmental disabilities, among many other things that it does. And in that bucket, most of the funds are spent on what's called home and community-based services. So this is an alternative to institutionalization. So originally, Medicaid funding was really focused on people who were in, quote unquote, institutions, but then they created something called the waiver. So instead of using the money in the institution, you could use the money in the community, in your own home, somewhere else, a place that you have control over. And HCBS has become increasingly popular across all the states, and it's also cost more and more to the federal government. What happens is the federal government provides matching funds to the states, and then the states can decide how much really they want to spend on Medicaid. And a lot of them don't spend a lot, and a lot of them spend, many billions. And it's that sort of soup of federal dollars with state dollars that funds those services that your child might be receiving in the community. Most notably when it comes to our population, a lot of this money goes to these agencies that provide like group homes, or that provide supported living assistance, right, in your own home, et cetera, et cetera. And then there's also medical care as well. So I hope that, I don't know, Melissa, if that's like too broad a brush, but just so people have some understanding where you sit in this. Yeah. So
yes, absolutely. CMS does a whole lot of things, and it's easy to get kind of lost in the organizational structure. So yes, I sit in a group in the Center for Medicaid and CHIP Services. CMCS is one center in the Centers for Medicare and Medicaid Services. And so the Medicaid program is run out of this center, and within that center is my group, the Disabled and Elderly Health Programs Group, which includes all of the benefits for Medicaid individuals, from acute and primary care to preventive services to long-term care and home and community-based services. And that lens is the lens through which I'm going to be talking to you today, and it's the lens through which we provide a ton of guidance to our state partners in helping them implement their program.
And this is something that's important for people to understand, that your group does not implement the programs, the states implement the programs. And you are kind of a checker, a quality checker, a guidance, a fact, explain a little bit more how you interact with the 50 state programs, or more than 50 state programs.
Right, yeah. So the number, I think, is 56 between the 50 states, DC, and the territories, the US territories. And all of them are running their own Medicaid program, because Medicaid is this unusual arrangement of a federal state partnership. If you take a step back and look at the Medicare program, that is a national program administered out of CMS. And so Medicare is Medicare. There can be variation depending on if you're in a managed care plan or not, but otherwise, regardless of where you live, you are able to receive the same benefits. That same thing can't really be said of Medicaid. There are some statutory obligations for states. And so some services that all states have to provide, like hospital care, physician services, home health services, nursing facility services of interest. And then there's a whole host of other services that are optional. And so the state really gets to determine if they're going to provide those or not. And all of these home and community-based services, these alternatives to institutionalization, are under this optional category. And so it's really critical to first understand what Medicaid services your state makes available, because there's a large amount of discretion available to states. There are some requirements in our statute, which was handed to us by Congress, and which we take and then issue a regulation to implement. So it goes, kind of congressional legislation is at the top. They tell us, here is your guiding framework for Medicaid. And then we as CMS issue regulations to provide a little bit more meat on that bone for how we're going to effectuate this legislation. And then below that comes other types of policy guidance that we issue to provide more explanation about things. And so within that rubric, we are having conversations with states every single day. That is our bread and butter work, because there are some expectations that states must adhere to as they are delivering services in Medicaid. And yet there's a lot of space for them to be making their own decisions. And so sometimes our relationship with the state is to make sure the state is transparent with us as the federal government and with their provider communities, beneficiary communities, family members, advocates. And so a lot of the work we'll do is to make sure the state is describing accurately for our benefit and for its stakeholders how it is implementing its Medicaid program. And if we find that a state is running afoul of a federal parameter, then we will intervene with that state and say, we need to have a conversation to make sure you're on the right path.
Got it. One question we get a lot is, you mentioned that Medicaid for HCBS services are basically an optional program for the states. People ask us, okay, I can't access HCBS for my kid, like I can't get a waiver, right, for their young adult. Can they get other Medicaid funding? For example, in an ICF, isn't that an entitlement? How do you respond to a question like that?
Well, it's a statement of fact that, as you said, at the beginning, the Medicaid statute has been kind of a patchwork and an evolution, and you can trace amendments to the Medicaid statute and kind of figure out what was happening in terms of the national conversation around healthcare at that time. When Medicaid was first authorized in 1965, there wasn't really anything known as home and community-based services. What the healthcare system knew then was doctor visits, hospital visits, and nursing homes. And you can see how the Medicaid menu has evolved over time, but it's really since the early 1980s that there was this real recognition in Medicaid that there should be some really sound alternatives to institutional services. And that's when you see the advent of the home and community-based waiver program. That's an optional program for states to provide services at home and in the community for individuals who otherwise would require services in an institution. So people who would otherwise be in a nursing home or otherwise be in a hospital or otherwise be in an intermediate care facility for individuals with intellectual disabilities. That was the very first step congressionally towards recognizing the need for alternatives to institutional services. The ICF benefit has been a part of the Medicaid program for a long time. And that is the institutional equivalent for home and community-based services for individuals with intellectual and developmental disabilities. And because of the way the Medicaid statute is written and the flexibilities that states have in crafting their waiver programs, it is also a statement of fact that there could be easier access to institutional services than a waiver slot providing home and community-based services. States are allowed to define their waiver program to provide services to a set number of individuals. They can cap enrollment, in other words, and say, I'm going to offer this waiver to 200 individuals. A state can exceed that at their discretion. And so some of these waivers are very, very large, but a state has the ability to say, I'm going to operate this waiver for the first 200 individuals who qualify for these services. And if you're number 201, then you are likely going to find yourself on a waiting list. A waiting list doesn't really appear in the federal statute, but it is kind of an organic offshoot from the fact that a state can limit enrollment into a waiver. And in some states, the waiting list is quite long. And unfortunately,
we hear about that all the time, of course, yes.
And unfortunately, waiting lists have particular relevance for waivers serving individuals with intellectual and developmental disabilities. There is more likely to be a waiting list for those waivers than waivers serving individuals who are older adults or individuals with physical disabilities or individuals with HIV/AIDS, for example. And you can see the reason for why that is. Some individuals with an intellectual or developmental disability will need lifelong care, and the state needs to understand what the implications are of that cost-wise, as they are responsible for some of their expenditures in Medicaid. They receive federal dollars to offset those expenditures. But because these are optional programs, states need to take a look at their fiscal picture and their provider capacity to deliver home and community-based services. And that often results in pretty defined population of people who can receive waiver services, and then people who don't have a slot in that waiver end up needing to look elsewhere. They either find services that are not funded by Medicaid. They rely on friends and family and natural supports, for their services. They could end up in an intermediate care facility, and so that is an accurate description. What those individuals are facing, is unfortunately, a shared experience that people all over the country are having.
Well, I think that you just circled around the core issue, right, that we're facing as an autism community. By the way, before I go into this, there was a report that came out last month showing that autism rates in Medicaid have grown more than 3.3-fold over 8 years, 2008 to 2016. Did you see that?
I have heard those statistics, yes.
Yeah, I mean, a giant jump in autism rates. And again, this isn't people say, oh, well, autism, we're just noticing it better. As you just said, people who enter the Medicaid system have to have a pretty significant level of disability. And these are people who entered because of disability, not because of income, for the most part. And we can see, if you look at the CDC rates, that's just going to keep rising. So we have a growing population in need of Medicaid services. But as you said, states can be very reluctant to actually fund more waivers. They put caps on it because, as you said, this is a lifespan condition. It's very expensive. And states, let's be brutally honest, just don't want to spend the money on the developmentally disabled. I mean, it's just not their priority. They have other things that they want to do. They don't want to raise more taxes. And sometimes they just don't want to face facts. So as you said, in Medicare, there you have what's really an entitlement, a federal entitlement. Then you have Medicaid for the IDD and the autistic, and it's not really an entitlement, depending on how your state runs it. I do want to ask you a question about ICF. So when people go to their state Medicaid agency and say, hey, I need, a residential placement for my child, it's not like they say, here's an ICF for your child. they tend to say, we're closing the ICFs, sorry. What is the parent supposed to do? They're on a wait list for a waiver. They can't get services through HCBS. They can't get services through ICF. And they sometimes can't take care of their kid. Their kid ends up in the hospital, really in the ER, sometimes for months. What's the workaround for a parent who's in that situation?
Yeah, I would say a couple of things. As states are determining the scope of services to offer in their programs, they are weighing a lot of different variables. It's quite a complicated environment right now to be running a Medicaid program. Things were kind of balancing on the head of a pin before the pandemic in terms of the stability of the direct service workforce. And those individuals, as you and your members know more than I do, those members that workforce is so critical to meeting the daily needs of individuals, whether those needs are literally getting dressed in the morning, getting out of bed, or more towards socialization, reminding individuals about, different kind of safety precautions, being a companion to an individual as they're engaging in various tasks. And without that workforce, there are some pretty significant implications and a real likelihood of people going without services that they've been assessed to need. And this was a national problem across the board for HCBS, individuals with intellectual disabilities, older adults, individuals with physical disabilities, individuals with behavior implications. This was a nationally recognized challenge before COVID, and COVID has just, totally upended that system even more. And so states are balancing their goals of serving as many people in the community as possible. Certainly COVID was another reminder of the implications of being in a large congregate setting. And it brightened even the spotlight that was already there on the need to rebalance the long-term care system away from reliance on institutional services and more toward home and community-based services. But in order to do that, the provider infrastructure needs to be in place. The workforce needs to be in place to make sure individuals who are living in the community have their needs met, not just occasionally, but every single day. There is a specific statutory requirement of states to ensure the health and safety of individuals in the waiver. And so states have to be able to do that. And they need the provider stability to do that. And so states have really been grappling with an upended workforce that makes things even more challenging than it was pre-COVID. Luckily, there have been a couple of options given to states in the form of additional funding, and I'll get to those in a minute. But to circle back to your question, you're exactly right. A lot of states have worked very hard over many years to reduce, if not eliminate, the presence of intermediate care facilities in their state. And that could be either because they, as a state, don't want to be in the business of institutionalizing individuals with intellectual disabilities. It could be that they have been in consultation with the Department of Justice on ways to increase that state's compliance with the Olmstead Supreme Court decision, which requires individuals with disabilities to be served in the most integrated setting appropriate to their needs. And so you have these converging rows of fewer institutions available across the country, and in some states, 0 institutions available, and yet an unstable home and community-based service infrastructure that can therefore enhance the reliance, at least temporarily, on institutional services. It is a very uncomfortable place to be. And there are times when families find themselves having conversations with their Medicaid agency about, if there is no ICF placement for my child here in this state, is there a placement in another state that that can be effectuated? And the difference and the outcome of that decision could vary based on the age of the Medicaid beneficiary that we're talking about. If an individual, if the Medicaid beneficiary, the child in this case that we're talking about is under the age of 21, then a state does have the responsibility to find an out-of-state placement, an out-of-state ICF placement, if that child needs an institutional level of care and the state doesn't have that type of institution within its own borders. And so, you know, that the outcome of a child being in an out-of-state facility is never one that's talked about lightly. The implications of that distance and separation from family and friends and known environment is not without peril. But those decisions are the type that need to be weighed very individually between the family and the Medicaid beneficiary and the medical team to figure out what really is best, you know, for that individual. If we're talking about a beneficiary over the age of 21, states don't necessarily have to offer that benefit out of state. But if they are offering a waiver, a home and community-based waiver for adults with an intellectual disability or a developmental disability, they need to have that institutional alternative available for those individuals. So let's say a state has a waiver that is serving 200 adults with an intellectual disability. For those 200 individuals on the waiver, you know, they need to have an institutional equivalent, you know, to be able to choose from. That doesn't mean the state's necessarily going to be able to meet the institutional needs of any Medicaid beneficiary in that state. And so is it a perfect solution? No. And of course, it goes without saying that we at CMS and the enormous majority of the states really focus on supporting the home and community-based services framework, and would love, in the enormous majority of times, for it to be the default service and rely on an intermediate care facility or any other institutional service only when there really is no other alternative. You know, do we recognize that for some people, for some periods of time, an institutional setting might be the most appropriate? Certainly, we're not going to substitute our judgment for that of a beneficiary, his or her family, you know, their medical team. But as a federal government goal, it is certainly to make sure that for as many people as want to receive home and community-based services, they have the option of doing it. I mentioned that this is a really tough environment to be delivering services in. And, you know, the national picture, you know, during the public health emergency was one of such disruption. States are still able to make use of extra funding made available to them in the American Rescue Plan Act, which passed in March of 2021. And it authorized some additional federal funding for home and community-based services, and it defined home and community-based services in a really broad way. So it allows states that are offering those services to pull down extra federal dollars and benefit from those extra federal dollars and use those funds to do other extra things in their HCBS system. by and large, almost every state used a good chunk of that funding to try to shore up their direct service workforce, because in every state it was at a crisis level. And so there were some infusions of funding, into the DSP workforce. And, hopefully that has brought at least some temporary relief, temporary stability. This is time limited funding. States are still able to spend those funds, and they'll be able to do so for just under 2 years. States will be able to use that enhanced funding made available under ARP through the end of March 2025. And so hopefully that will allow that kind of sustained infusion of extra federal dollars will help stabilize the workforce. Whether it's really a silver bullet, I think we'll have to wait to see. And I don't think we're expecting it to be, but it will help. All those activities are so necessary to make home and community-based services a reality. And even, outside of that extra funding, states are also finding, and you and your members are also likely finding, that the workforce on the institutional side is also not where it should be. And so, we're having conversations around, what that looks like, what an unstable institutional workforce looks like, what are the implications of that, and what our next step should be.
I think what we're seeing is so many levels of crisis. Of course, there's the waitlist crisis, people who can't even get Medicaid services at all. And then there are the people who do have the waivers, right? They're so lucky they get the waiver, but it becomes a waiver on paper, and it doesn't translate into services on the ground because the agencies refuse to serve usually adults, sometimes children, but usually adults with severe autism. The agencies can pick and choose, and they do not choose people who are, ripping apart furniture and who are blowing holes in walls and in windows and who are eloping and who are screaming. Those are much more complex and difficult cases. And so we hear regularly from people who say, well, I have a waiver, but it's worthless. And then even worse than that, when in some states, when the parent is desperate, and the parent, is obviously sometimes living in poverty because they're taking care of a very, very difficult, challenging individual, the states won't let that parent be the provider. So the parent can't get paid to do this insanely difficult work. The waiver on paper problem, I think, seems to be growing with the workforce crisis. I see there is this infusion of money in the rescue plan. What else is happening to improve the bleak outlook for having enough DSPs to serve our very rapidly growing population?
Yes, I wish I had a nice, concise answer that would kind of turn the tide. On the one hand, I would imagine that, most providers are not participating in HCBS programs so they can turn people away. I imagine that a decision to say that they can't accept a new individual or they can no longer serve an existing client is based on an assessment of what that person needs and an assessment of whether that provider has the staff to be able to provide services for that individual and to provide services to other individuals who are receiving those services.
Yeah, I'm not saying, I'm not attributing malice on their part at all. It obviously, when you're dealing with somebody like my daughter, who's just chill and hangs out and is nonverbal autistic, but easy peasy, that's one thing. If you're dealing with someone like my son, who might be ripping apart the furniture, that's a whole other thing. And then the providers, frankly, it's more cost effective for them to serve my daughter. It's not that they're evil, but it's a business decision, and they have, does CMS have any discretion to ensure that the waivers are supporting people with the highest needs?
The tools that CMS has really are to make sure that states have what they need from us as they are making decisions about how to operate their waiver programs. there are some decisions that have a big federal influence and other decisions that really are solely owned at the state level. And our goal as working with the states as our partner in implementing the Medicaid program is to make sure they understand where they can make decisions, how those decisions are influenced by federal policy and expectations. And to the extent a state needs to kind of cut new grounds, new policy grounds, they come to us to say, I need to make sure I'm doing this in a way that will not jeopardize my federal funding, or if they need to see if they can access Medicaid funds in a different way. And so a lot of these decisions that are impacting the types of services made available, the amount of people served in a waiver, for example, those are all going to be made at the state level, but the state is looking at the realities of their program and the realities of their provider infrastructure. And so, the actions that we're talking about now, besides just infusing funds to the direct service workforce, we're looking at other ways that try to distinguish that profession and make it attractive and competitive, which in and of itself is a little difficult. We're living in a time when minimum wage is increasing all over the country and in many types of jobs, which is really wonderful. And yet it makes it even more challenging for these direct care jobs to really stand out, and requires extra resources from the state to really differentiate these jobs from other jobs, and attract and keep the right kind of worker. People need to be even the most mission-driven person needs to feel like they've got a future staying in this job. And is there upward mobility? Is there the ability to talk with other people who are providing those same services? I've never walked a mile in a direct service worker's shoes, but I hear that it can be kind of lonely if they are going from home to home to home, never laying eyes maybe on another person providing those same types of services. So what are ways that we in the states can make this job that is enormously critical? How are ways that we can attract people to it, keep them there? We're never going to solve, with the swipe of a pen, the funding issues, that are at the heart of Medicaid reimbursement. But are there other ways that we can recognize individuals for attaining different levels of training, offering reimbursement commensurate with the level of training that we've had, offering other ways to develop a real sense of pride in this field? These are all irons in the fire that we're working on. We did release within the last couple of months, I think, and it's on Medicaid.gov, some tools for the direct service workforce, particularly in self-direction. And I'll take this opportunity to plug self-direction. And then that's going to seg me into addressing your point, Jill, about paying family members as providers. But self-direction has been around for a long time, and we're all for it. And it has really been a positive during the pandemic. States embraced self-direction, even the ones that really hadn't before, because it was a way to recognize and bring into the Medicaid fold non-traditional providers that hadn't really been labeled Medicaid providers before COVID. And so one of the hallmarks of self-direction is to allow an individual to tap a family member, a friend, a neighbor to be their service provider. And the benefits of doing so, I don't have to reiterate to you and your folks, but there's an awful lot of avenues in Medicaid to allow those self-directed programs to flourish. And so we saw states do that. And it allows for differently qualified and differently positioned people to be considered Medicaid providers for the purposes of delivering these services. And it really allows the individual and his or her family to be driving the bus on, here's the qualifications of the person I want to be coming into my home and providing these services. And it authorizes me to say, you know, I think my cousin, my neighbor, my whoever best fits the bill for who I'm looking for. And I am pretty darn sure that they're going to show up on time and consistently, you know, because they know I can get a hold of them, you know, very, very quickly.
Mhm.
And so, you know, for states that haven't really embraced self-direction as much as they could, we are encouraging them to do so and making ourselves available to provide technical assistance on how to actually stand that up.
Yeah,
But one of the
go ahead.
offshoots, go ahead. Go ahead.
Oh, yeah, I would just add that if a state doesn't have self-direction as part of its waiver program, it should still find a way to fund these parents and family members. If no one else is available, that's what we're finding, right? These people have waivers on papers, they have no other help. I feel like there maybe could be a regulation, maybe not even a piece of legislation, a regulation that makes it clear that that the parents are entitled if that's the necessary, you know, route forward.
Well, there's some good news in that regard, in that one of the other implications or outcomes of the public health emergency is that this issue of reimbursing parents and family members as caregivers has never been more front of mind before.
Right, but those are sunsetting, right?
Not necessarily.
Oh, okay.
Not necessarily. And so you're absolutely right. A lot of states availed themselves of COVID specific flexibilities to,
Right.
for the first time, authorize family members, including parents, to be paid caregivers. And when we first started hearing about the May 11th date as the end of the public health emergency, and then that kind of, depending on the emergency authority used, that was either going to be the end date for some of those flexibilities, or for some of them, the flexibilities authorized through the 1915C waivers. We look 6 months down the road from May 11th, and that brings us to November 11th. And so states are like, okay, I now know when these flexibilities will be sunsetting. And we've been working with states ad nauseum for months in preparation, even before we knew dates associated with the end of the public health emergency, to say, look, there's going to become this period of, oh, can you hear me?
Wait. Okay, sorry. Can you hear me?
Yes, can you hear me?
Siri responded to my hand on my sorry about that. That was inadvertent Siri interference. Go away, Siri. All right, go ahead. I'm so sorry.
No,
Anyway.
no problem. So this has ushered in this period of great unwinding, and I'm putting unwinding in quotes because that's a word that CMS has never uttered more than, you know, in the last couple of years. And we are working with states to say, take a look at the flexibilities that you have stood up under the public health emergency. There is the ability in many cases for those flexibilities to be built into the underlying and ongoing operations of Medicaid programs. As is the case so often with Medicaid, some of the conversations that we have with states become very technical and boil down to an authority by authority conversation. Mm-hmm. Each authority has its statutory direction. Some statutes are written very, very broadly. Some, particularly those that were written decades ago, are written, you know, very narrowly. Hmm. But particularly, I'll start with the 1915C waiver authority, since that seems to be the most relevant. You know, there's nothing in the waiver statute or regulation that prohibits family members from being paid caregivers. Mm-hmm. What the state needs to say to us is that the family member, and let's use a parent as an example, the parent needs to be providing what is called extraordinary care, which sounds a little scary and sounds like it is this standard that's going to be very hard to meet. But really all it means is that the parent is receiving Medicaid funding to provide services above and beyond that which a parent should be expected to provide to their child, if that child did not have a disability.
Right.
So
which
we're
is a
not
very easy
paying a
bar to
parent
reach in our
to parents that their child who has a developmental disability, a physical disability, a traumatic brain injury, what we're paying Medicaid, or we're paying that parent to deliver those Medicaid covered services that their child needs because of their health condition. And that in and of itself really is extraordinary care. That's care that a parent of a non-disabled child would not, be called upon to provide. And so we have had national conversations with our state partners to say there's room there, for all of you states that made use of COVID flexibilities to authorize parents as caregivers. There's room under your regular 1915C waivers.
Right.
And if you want to continue this flexibility, come talk to us and we'll make sure you describe it in the way we need you to describe it. But again, that makes it at state discretion. States have to decide they want to continue this beyond the public health emergency.
Got it. Okay, this is what I'd like to do at this point, because we haven't gotten to the settings rule yet, and that's a big issue for our audience. I'm going to make this a two-part interview. So we're going to sign off now with part one. Stay on, Melissa. Don't go anywhere.
Okay.
And then we will have a shorter, separate podcast episode about the implementation of the settings rule in the states. Okay, so signing off for now, but we'll be right back. Thanks for tuning in to Autism Confidential. If you'd like to learn more, share an idea for an episode, or become a sponsor, please visit us at autismconfidential.org. The views expressed in this podcast are solely those of the individual speakers. Content presented is for informational purposes only, and we do not provide any medical or legal advice.